Well, good afternoon, everyone. Welcome to Critical Advancements, an industry-only special opportunity brought to you by CHEST. All opinions expressed and information provided as part of this program are those of the presenters only. The content of this program has not been reviewed by CHEST, and CHEST does not endorse or take any position regarding the contents, opinions, or information associated with this program. I'm DeMons Haynes, and I will serve as your moderator this afternoon. I'm a professor of medicine in the Division of Pulmonary and Critical Care at the University of Mississippi School of Medicine in Jackson, Mississippi. Our objectives this afternoon are several, and we'll cover those quickly for you. We'll recognize the impact of asthma exacerbations on the burden of disease for patients with asthma in the United States. Gain an understanding of the role of variable airway inflammation in asthma exacerbations and the consequent burden of systemic corticosteroid exposures. Understand how to help recognize which patients have uncontrolled asthma and are at risk of future exacerbations. And finally, we'll examine data on a new rescue therapy option to help prevent asthma exacerbations in our patients. Joining me today are two esteemed panelists, Dr. Monica Kraft, who's the System Chair for the Department of Medicine at the Murray M. Rosenberg, and she is the Murray M. Rosenberg Professor of Medicine at the Icahn School of Medicine at Mount Sinai in the Mount Sinai Health System. Also joining us today is Dr. Karthik Shenoy. Dr. Shenoy is Professor of Thoracic Medicine and Surgery at Temple Lung Center at the Lewis Katz School of Medicine in Philadelphia, Pennsylvania. So today, Dr. Kraft and Dr. Shenoy will walk us through some of this information, and we will have opportunity for questions at the end. You'll be able to submit those in the Q&A box. We know some of you have pre-submitted questions at your registration, and we'll go over some of those as well. So join us today as we talk about asthma. And to get us started, we will go with Dr. Kraft.
Great. Thank you so much. It's a pleasure to be here, and thank you all for taking the time to join us today. So I'm going to take you through and talk a bit about asthma exacerbations in the U.S. And, despite the advances that have been made in our field and the immunology and the understanding of the immunology, asthma exacerbations, especially severe ones, are still a problem. There's still over 10 million annual attacks, 1.8 million ED visits, 170,000 hospitalizations, and 65% of patients more than 12 years old or 12 or more with persistent asthma have used oral corticosteroids, which is these are really profound numbers. And in 2020, 25.3 million people in the US were living with asthma. So 25 million, again, a huge number. And so severe exacerbations really contribute significantly to asthma morbidity. Next slide, please. So over the decades, we've seen some improvements. Clearly, we have new treatments out, which have been fantastic. We have a lot more to offer our patients, from biologics to more potent inhaled corticosteroids. So that's all been a wonderful advance, and it's a great time to be in the field. But I would say we still have work to do. So if you can see, the asthma prevalence in the US is still significant. It's actually on the rise. And you can appreciate how hospitalizations have gone down. That's the orange line. I don't know if you can see my arrow here. And yet ED visits really haven't changed a whole lot, despite the introduction of the anti-IgE antibody, omalizumab, LAMA approved for asthma in 2015, IL-5 ligand and receptor antagonists in 15 and 17, the IL-4 and 13 receptor, IL-4 receptor alpha inhibitor introduced in 2018, and then triple therapy in 2020. So the bottom line is the burden of exacerbations still persists. Next slide, please. So airway inflammation is really central to asthma, and we've known this now for a couple of decades. So that's the good news. And we know that inflammation augments airway narrowing, and here's a cartoon that illustrates this. And you can see on this side of the airway, it's a very open, a very thin airway epithelium, airway smooth muscle there, very open, muscles are relaxed. If you look on the right side, you can see a very narrowed airway. There's more smooth muscle than in the normal situation or the non-asthma situation. The airway epithelium is far from an innocent bystander. It very much is involved in the inflammatory response. with its mediators, but also producing mucus, which also contributes to airflow obstruction. And so, and you can see a thickened airway epithelium with fibrosis leading to a narrowed airway, which can vary over time, vary in intensity, and lead to exacerbations. Next slide, please. And we know that certain exposures, both to allergic and non-allergic triggers, can lead to variability in inflammation and symptoms. And we know this when we see our patients in the clinic, that asthma is not static. It can be worse at night. It can be worse after exposure, whether to allergens in the setting of allergic disease, to other exposures. We've had a lot of issues with poor air quality over the last 6 to 9 months around the country, around the US, that have really affected airway caliber, if you will. And so treatment with maintenance therapy, while it's essential, may not be quite enough or may not always address these changes in airway inflammation. Next slide, please. And so what's interesting is if we look at the real world use of maintenance therapy, we know when we tell our patients to use, 2 puffs twice a day of an inhaled corticosteroid LABA combination, or once a day, maybe in some cases, we may or may not get complete adherence. And I think this slide really illustrates that we rarely do. And so if you look at it, you can see that asthma control is measured by short-acting beta agonist refills. So in those who are well controlled, they have 1 refill a year. That's only about 28%. 2 to 3 per year those patients are not well controlled. That represents about almost 47% of population, and greater than 4 or more refills per year. And this is of the short-acting beta agonist. Remember, there's no anti-inflammatory in that medication. That represents about 25%. And then if we look at adherence to maintenance medications, and this is based on sort of number of refills of the controller medication, you can see that in each of these groups, the best we have is 66%. And then, of course, if we look at these same groups and look at the percentage of patients with 1 or more exacerbations per year, you can see that, again, those numbers are quite high, reaching 59% in those that are very poorly controlled. So I think that the message that I walk away with when I look at a slide like this is that patients, one, they don't always want to engage in maintenance therapy. They may know that it's the best thing for them. Life gets busy, they forget, they may not understand what the benefits are, or they may not be having symptoms and feel the need to take it. And hence we have data like I'm showing you today. Next slide, please. And really, exacerbations occur despite good control and high maintenance adherence. And I think that's also another take-home message, that even in the best of circumstances, when we have the most adherent patient we can imagine, which is a wonderful thing, our patients still have exacerbations. And so this is an interesting study of about over 350,000 patients with asthma, 12 or more years of age, looking at Medicaid or employer-sponsored Medicare insurance. It looked like 31% were well controlled. So they were refilling 1 short-acting beta agonist refill per year. 13% had high adherence. And then 4% had good control and high adherence. Now that's a very small number. And of the patients with good control and high maintenance adherence, 36 to 54% still had 1 or more exacerbations, just because there are exposures in the environment, whether it be infectious or air quality, like we talked about, allergens, et cetera. There's just a lot of things that bombard the lung. And despite everyone's best efforts, exacerbations still happen. Next slide, please. So this is the AIR-Q. It's another kind of rating measure that we can use, and it's really the Asthma Impairment and Risk Questionnaire. And I'm not sure how familiar you are with this one, because there are others that are a little bit more commonly used, but I find this one particularly interesting because it's a 10-item equally weighted low literacy demand, which is important, yes/no questions. There's 7 impairment and 3 risk items. It has 90% sensitivity to identify well-controlled versus not well controlled or very poorly controlled, which is good. We want to do that. And that's what many of our other questionnaires address. But then it also has specificity to identify the very poorly controlled versus not well controlled. And I think what I like about it is it looks at impairment, but then it also looks at risk, which is something that some of our other questionnaires don't do exactly. So next slide, please. So asthma control in clinical practice is sometimes overestimated because it doesn't take exacerbation history into account. And that's what the AIR-Q does by looking at risk, because we know an exacerbation then increases risk for future exacerbations. So as an example, if you look at 32% of patients who assess themselves as completely or well controlled had at least one or more chart documented exacerbation in the past year. 30% of patients assessed by their healthcare providers as well or completely controlled were also in that same group, and 29% classified by as well controlled by the ACT, the Asthma Control Questionnaire, and this is score greater than or equal to 20, also had one or more chart documented exacerbations. So even though the questionnaire suggests good control, and really these are often a month recall or maybe several months if you're talking to a patient, it may not really take the whole span of a year into account. Whereas the AIR-Q assesses control by both risk and impairment. And in this case, only 60 patients rated as well controlled by the AIR-Q had one or more exacerbations. So it takes both sides of the equation because we know prior exacerbations are a strong predictor of future exacerbations. Next slide, please. So, and there may be consequences to overlooking exacerbations. We know that when our patients have these experiences, not only are they very stressful, they are not being able to breathe itself is an incredible stress, but then what it means for their health care, their health moving forward, and to their lungs around airway injury, repair, et cetera, and loss of lung function. And so this is similar to what I had talked about in the previous slide, looking at how well the AIR-Q did with regards to really looking at how it captures exacerbations relative to other ways. So this is a study looking at, or a post hoc analysis looking at patients who rated themselves as very well controlled versus physician rated as well controlled, ACT rated, and AIR-Q rated. And these are the number of exacerbations that you can see on the top of each of these bar graphs. So putting into numbers basically what I just showed in the last slide. Next slide, please. And one of the other pieces that I didn't mention is that the treatment with systemic corticosteroids, while can be extremely effective when you need them, I feel like I have a love-hate relationship with oral steroids, they do contribute to burden of disease. And it's actually, if you look at lifetime systemic corticosteroid exposure, it's very concerning in terms of the comorbid conditions that are associated with that. And for instance, from anywhere from 500 to less than 1,000 milligrams lifetime exposure, there's a risk of type 2 diabetes and depression, anxiety. When you start to move into 1,000 to 2,500 milligrams, then you're starting to see other comorbidities. Yes, you see diabetes and depression, but also renal impairment, which is something we don't necessarily talk about as much with regards to steroids. Cataracts, cardiovascular disease. We don't necessarily talk about that so much as side effects of steroids. Pneumonia, of course, we learned about that through our studies in COPD, and of course, osteoporosis. So therefore, we have to remember that while we may need oral steroids at times to treat our patients, the best route is to think about being proactive and trying to avoid this scenario. So next slide, please. And then treatment of exacerbations with even one or two short bursts is associated with an increased adverse health conditions. This gives me pause, because if you even look at if you look at the burst one, where you've had below the lifetime risk of the systemic corticosteroid exposure threshold, right around 500, you see burst one. If you're at 500 milligrams, that's when you start to see the depression, anxiety, and greater than 1,000, as we talked about, renal impairment, cataracts, cardiovascular disease, pneumonia, osteoporosis. And you can see how, depending on, and my experience has been with patients that sometimes they feel like one or two bursts a year is not a big deal. They feel like they just take their bursts, they're done, that's it, and it's okay with them. And I would beg to differ on that. And I think it's important for us to educate our patients that we really want to do whatever possible to avoid bursts, because that's really not where we want to be. If we need it, we need it. But because of now what we've learned about the lifetime exposure and what that can mean. Next slide, please. So if a window opportunity may exist to prevent an exacerbations. And we sort of have that sense, and we'd love to be able to intervene. And I'll often ask my patients, especially those with more severe disease, when do you feel like the tide is turning? What are the subtle symptoms that you're having? And I'll have them really think about it. And unfortunately, if they do have an exacerbation, we'll talk about it right then and try to kind of think back. What is it that really triggered? And when did you know that you may be heading down a bad path? And is there anything we can do even before that time? And so rising inflammation can result in decreased lung function, increased symptoms, and increased use of rescue therapy. And it may even be before it gets to that point. It might be a very subtle cough that normally doesn't exist, that then that patient knows will lead to this scenario. So interrupting a rise in inflammation may prevent the occurrence of an exacerbation, and obviously avoid the need for systemic steroids. Next slide, please. So we know a short-acting beta agonist treats symptoms through bronchodilation. That's great, but it has no anti-inflammatory effects. And if you look at on the right side of the slide, you can see the short-acting beta agonist binds to the beta receptor, increases cyclic AMP, leads to airway smooth muscle relaxation. All well and good. So it's short-term, usually 4 to 6 hours in duration of effect. But as inflammation starts to increase in the setting of exacerbations, that's going to change and lead to that airway narrowing we saw earlier on in that cartoon. And with all the, especially with the airway epithelium starting the cascade of inflammatory events. And I think then that alone can lead to airway narrowing that ASTABA won't touch. So the genomic effects of inhaled steroids are anti-inflammatory gene transcription and beta 2 receptor gene transcription. So those are good, and a decrease in pro-inflammatory gene transcription. And then early effects, usually the non-genomic or the beta 2 agonist induce bronchodilation and then a reduction in bronchial vascular blood flow that often leads to some improvement in lung function early on, and obviously decrease immune mediators. Next slide, please. So even an as-needed short-acting beta agonist and inhaled steroid in 2 separate devices decreased exacerbations. And this is the PREPARE study. And this is a reliever-triggered inhaled corticosteroids in U.S. Black and Latinx adults with moderate to severe asthma. There's over 1,000 participants evaluated. And so compared to SABA alone, the as-needed SABA plus inhaled steroids, ICS, decreased the risk of severe exacerbations by 15%. And reduced the number of missed days of work, school, and usual activities, and improved asthma control as measured by the ACT. So that's in 2 separate devices, and an as needed, and it was an as needed combination of both. So that's interesting, right? That you can add that to a regimen and see that and see improvements already. Next slide, please. Now, this is an interesting study by Lagogo and colleagues looking at what the decrease in steroid exposure would have been if there was a short-acting beta agonist and inhaled corticosteroid in one device, so that every time the patient reached for the albuterol, that it had a inhaled steroid, in this case, budesonide as an example. And so these are the micrograms of short-acting beta agonists and of the projected additional ICS exposure, which you see in green. So you compare that to, these other parts of the graph, which are the FDA approved upper limit of the HFA inhaled steroid or the dry powder. And you can see that using something as needed for symptoms that has an anti-inflammatory in it decreases overall exposure to inhaled corticosteroids. And this was a model, a projection. But I find it interesting because at the end of the day, we do want to limit steroid exposure, whether it's oral or inhaled, in a safe way to control symptoms. We want it all, basically. And so I found this analysis very interesting for that. Next slide, please. So if we look at our guidelines, NAEPP and GINA also report that inhaled steroid and fast-acting bronchodilators as rescue reliever in patients 12 and up. So the National Asthma Education and Prevention Program did a focused update in 2020, and they addressed a few things, including the as-needed inhaled corticosteroid and short-acting beta agonist. And remember that had not been part of the guidelines at that time, and so recommended for step 2, 3, and 4. So we're moving to mild, persistent to moderate. to use daily and as needed low dose combination inhaled corticosteroid formoterol, especially for step 3. And then for step 4, daily and as needed combination medium dose inhaled steroid and formoterol. And even back at step 2, which is really very mild asthma, a low dose inhaled steroid plus as needed short acting beta agonist, or you can use as needed ICS and short acting beta agonist. So NIH was getting in the game with this as needed anti-inflammatory and bronchodilator use. Now, GINA has really made it really part and parcel of their guidelines and really have added it really to all the steps. And in that SABA should actually not be used as a reliever. And that was a change that came to the guidelines actually probably back in about 2020 or so. And because of the SABA alone does not reduce the future risk of exacerbations, nor does it have any anti-inflammatory effects. So similar to what was being done in the cardiology space, treating blood pressure and cholesterol proactively to avoid cardiac events, this is done as a way to reduce exacerbations, because we know now that even the mildest asthma, those patients do, or they can have severe exacerbations. And as you move up the steps to step 3, 4, and 5, which we're getting to moderate and severe, you can appreciate that low and medium dose ICS formoterol can be used both as controller and reliever. So that's called SMART. So that's single maintenance and reliever therapy. And step 5 is the add-on LAMA, considering biologics, etc. So that's where we get into the phenotyping in our biologics. The challenge here in the US is the use of ICS formoterol is not approved for both maintenance and rescue in the US. And that has to do with the labeling of these medications and how they're used here. So this SMART therapy, using one inhaler for both, is really used in Europe, but not here in the US. So recommendations for ICS formoterol are based on clinical data evaluating ICS formoterol formulations and strengths, not approved and not available in the US. Next slide, please. So what do we do? So we, in the GINA guidelines, if you look at them, there's actually an alternative controller and reliever track, and that would be track 2. So step 1 is the mildest asthma ever. And so whenever a SABA is taken, ICS needs to go with it. So it's the idea that, again, short-acting beta agonists should not be used alone. Then as you move to step 2, get to low-dose maintenance inhaled steroid. And then for the reliever, you can still use a short-acting beta agonist or an as-needed inhaled steroid short-acting beta agonist. And that really is in the background of all of the steps in this track. And as we move up to step 3, 4, and 5, as we move to more moderate to severe asthma, and we move up from low-dose ICS LABA to medium high dose to high-dose ICS LABA plus add-on LAMA, biologics, etc., we always have this as-needed, ideally ICS SABA in the background. Next slide, please. So I know I covered a lot of ground in a short period of time, so happy to answer questions after we're finished with the entire talk. But hopefully you can appreciate that the impact of exacerbations on the burden of asthma in the US is significant. Despite decades of scientific discoveries and updated management recommendations, our understanding of asthma has exploded, but we still have work to do. Variable airway inflammation plays a major role in the occurrence of exacerbations, while treatment with systemic corticosteroids increases the risk of long-term adverse health outcomes. So we're in a bit of a quandary. We know that even in our best circumstances with maintenance treatment, even in the most adherent patients, they can still have exacerbations that need oral steroids. So what more can we do? And in order to initiate educational and clinical interventions to help prevent exacerbations, we might consider a tool such as the AIRQ. We also have other surveys at our disposal, as you know, but the AIRQ is interesting in that it takes into account the control, but also the exacerbation piece, which the others don't capture. And there's a window of opportunity that may exist to prevent a severe exacerbation if symptoms and inflammation are treated concomitantly, as certainly we've seen in our guidelines, and we're going to hear more about that coming up. So thank you very much for your attention.
Dr. Kraft, thank you so much for that great review of the burden of disease, as well as reminding us about that underlying inflammation that our patients with asthma have that is always with them, and the information that you presented talking about the NAEPP focus update for those guidelines in the GINA report. I think that really helps us, and it's a great segue for Dr. Shenoy, who will talk to us about AIRSUPRA and where this might be used for our patients. Dr. Shenoy.
Thanks so much for the introduction, and I agree. It's such a great overview of asthma, where we're at now, and where we need to do better. I'm here to talk to you about AIRSUPRA, and AIRSUPRA is a combination of albuterol and along with that, budesonide. It's indicated for the treatment of asthma on an as-needed basis, and it actually has been shown to prevent exacerbation and reduce the risk of exacerbation in adult asthma patients. Now, it is 2 puffs is equal to 1 dose, and you're not supposed to take more than 6 doses per 24-hour period, meaning 12 inhalations in a 24-hour period. I would encourage you to actually go over and review the full prescribing information, and you can find this on airsupra.com. Next slide, please. Before I get into the data about AIRSUPRA, I have to go over some selected important safety information. Obviously, if your patient has a hypersensitivity to albuterol, budesonide, or any one of its excipients, it's contraindicated. Patients may still deteriorate on AIRSUPRA as well, so you have to inform them that if they're still continuing to have symptoms despite their rescue usage, they should contact you. Paradoxical bronchospasm has been shown with albuterol and can be present with AIRSUPRA as well. Discontinue AIRSUPRA if this occurs and prescribe an alternative agent. Cardiovascular effects have been known to be caused by beta agonists, and just like with albuterol alone, you need to be cautious with your cardiovascular patients. Next slide, please. So really, we're going to switch gears and talk about Mandala. Mandala was a very large clinical trial of about 3,000 patients. It's a phase 3 trial evaluating the safety and efficacy of as-needed albuterol, budesonide compared to an as-needed albuterol. And mainly, they were looking at the time to first severe exacerbations. Now, this trial did include individuals that were under 18 years of age, but for the purpose of this talk, we are going to be talking about patients that were 18 years of age or greater, which AIRSUPRA is indicated for. And as you can see in this schematic, there's about a 2 to 4 week run-in period where the patients used their as-needed rescue SABA. And then from that point, they were randomized to albuterol budesonide, the top dose, 90/80 micrograms, 2 inhalations as needed, and that is the prescribed dose for AIRSUPRA. The second group was albuterol budesonide at 90/40 micrograms, 2 inhalations as needed, and the third group was albuterol alone. They went through the study, they then monitored it for exacerbations and then other adverse events throughout the study as well. Next slide, please. So who are these patients? This is really important to figure out the inclusion criteria and major exclusion criteria. These patients needed to have symptomatic moderate to severe asthma. They'd had a physician diagnosis of asthma for at least 1 year prior to enrollment, and the patients needed to have 1 or more severe exacerbations in the 12 months prior to enrollment. They also needed to be on background scheduled asthma maintenance therapy for at least 3 months or greater, with a stable dosing 4 weeks prior to enrollment. They could be on medium to high dose inhaled corticosteroid, or they could be on low to high dose inhaled corticosteroid if they were used in conjunction with a combination agent such as a long-acting beta agonist. Since we're talking about the adult population, their pre-bronchodilator FEV1 needed to be between 40 and 90% of predicted, and they needed to demonstrate reversibility. These patients also needed to be symptomatic with ACQ scores of 1.5 or greater. Key exclusion criteria, COPD or any other significant lung disease, systemic use of corticosteroids within 3 months prior to screening, use of any biologic agents within 3 months or 5 half-lives before screening, and prohibited medications such as beta blockers, including eye drops, or any systemic cytochrome P3A4 inhibitors. And again, I would like to inform you we're specifically talking about the patients that are 18 years of age or greater in this talk. Next slide, please. So really looking at the adult population, comparing the prescribed AIRSUPRA dose and versus albuterol. The average age of the patients were right around the 50 years of age. The vast majority of patients were 18 to 65 years of age, where 25% were 65 and older. The vast majority of patients were white, about 80%. 20% of the patients were self-described as Hispanic or Latino. And since this was a worldwide study, about half the patients came from North America, Western Europe, or South Africa, and another half came from the rest of the world. Next slide. And here's a real big take-home point of the trial. As needed, albuterol budesonide significantly reduced the risk of severe exacerbation by about 28%. So the time to first exacerbation was reduced by 28% with the use of AIRSUPRA compared to albuterol. Next slide. In addition to this, there was also an overall 24% annualized risk reduction of severe exacerbations overall with the use of AIRSUPRA compared to albuterol, and a 31.5% reduction of annualized systemic corticosteroid dose with the use of AIRSUPRA compared to albuterol. So you could see overall a significant rates of reduction and significant rates of reduction in oral corticosteroid use, which is exactly what we want for our patients. Next slide. Looking at the adverse events, they're about similar between the two groups, where while there was a numerically higher amount of oral candidiasis, this was not statistically different comparing AIRSUPRA to albuterol. Headache, oral candidiasis, and cough were the main significant side effects in this trial. Next slide, please. So, important safety information. Really, don't exceed the recommended dose. Clinically significant cardiovascular effects can occur when you use excessive albuterol. Hypersensitive reactions, including anaphylaxis, can occur with albuterol, budesonide, etc. There is a risk of sympathomimetic amines. So AIRSUPRA, like all other therapies containing sympathomimetic agents, should be used in caution in people with convulsive disorder, hyperthyroidism, diabetes, etc. Hypokalemia can also be present in patients that use albuterol repetitively. So be careful with this in terms of using AIRSUPRA as well. And inhaled corticosteroids, just like any other inhaled corticosteroid, can cause immunosuppression and increased risk of infection overall. Next slide, please. As I stated before, oral pharyngeal candidiasis occurred with the use of AIRSUPRA, just like any other inhaled corticosteroid. And additionally, you need to watch out for relative adrenal suppression, reduction in bone marrow mineral density, glaucoma, cataracts. And while in the slide there's effects on growth, I want to remind you that AIRSUPRA is not to be prescribed to patients that are 18 years of age or younger. Next slide. Once again, most common adverse reactions were headache, candidiasis, cough, dysphonia. There are certain drug interactions that you need to be aware of. Strong cytochrome P453A4 inhibitors, azoles, may cause significant systemic corticosteroid effects. If you're really using AIRSUPRA along with an additional beta agonist agent, you really need to be careful using that, and significant side effects can occur. Beta blockers have always been implicated in bronchospasm with asthma. If you're using a diuretic along with AIRSUPRA, please be mindful of their potassium. Digoxin levels may decrease as well, and MAOIs and TCA should be used in real caution when you use any albuterol-containing agent. So next slide. In conclusion, AIRSUPRA is the first and only rescue medication approved in the United States for as-needed treatment and prevention of bronchoconstriction. And it's really been shown to reduce the risk of exacerbation in asthma in patients that are 18 years of age or greater. In the Mandala trial, AIRSUPRA significantly reduced the risk of severe exacerbation by about 28% compared to albuterol. It also significantly decreased the annualized rate of severe exacerbations by 24% and the annualized systemic corticosteroid dosing by about 31.5% compared with albuterol. Most common adverse events were headache, oral candidiasis, cough, and dysphonia. And given the significant burden of exacerbations in systemic corticosteroid exposure in the United States, AIRSUPRA offers the ability to treat symptoms and airway inflammation together to help reduce the burden of disease in our patients with asthma. Thank you so much.
Dr. Shenoy, thank you so much for that great information about AIRSUPRA and where it can be used for our patients. I'm going to end the slideshow so that we can get ready for questions and have everyone brought to the screen. And I'll start looking at some of these. The first question is about having access to the slides. So I don't know the answer to that question, so we'll touch base with the people at CHEST and let you know about that, about these slides. The next question is, I suspect patients are not using a spacer with this. Do you recommend use of one with this and really all similar inhalers? And Dr. Kraft, I'll start with you and get your thoughts, and then Dr. Shenoy.
You bet. I'm a big fan of spacers because I feel like if you just look at the anatomy, if you will, of these inhalers, it's not so easy to aim the medication to make sure it gets into the lungs. It can go a lot of different directions. And so I'm a big fan of spacers, and so I would recommend using one.
I would echo those sentiments. I'm a big fan of using spacers overall when they're appropriate for the agent that's being used with it. I think it allows for better drug delivery, and 100% echo those sentiments.
All right, and I thank you, Dr. Kraft. You were doing some things in the background in the chat while we were going over the presentation with the question about the AirQ. So I like that, and we see that. So I'll pull up a couple of other questions that have come in. One specifically, Dr. Kraft, I'll direct this to you, is about control of environmental factors. And it says, control of which environmental factors have been shown to actually improve asthma control?
Right. It's a great question because we go through a lot of our history to really determine what a patient's indoor environment is with regards to allergen exposure, especially if they have allergies. We think about dust, we think about mold, pets, all of that, whether they have carpeting, all these kinds of things. So if you look in the literature, there's a lot of literature, and there have been a couple of really interesting systematic reviews trying to take all of that into account. And looking at that data, there are some data to suggest that potentially cockroaches and reducing the burden of cockroaches can actually improve asthma control. What a lot of the studies look at is when you have the allergen, we know it makes asthma worse. However, does taking it away actually improve control? So there was a small study looking at cockroaches. However, I will say in Jackie, there was a very nice systematic review published in 2019 that really didn't come to any great conclusions. Now, they looked at everything. They looked at over 50 studies and really said it has to be a multi-pronged approach, that not a single intervention is really going to do it. So I still recommend doing this because you want to find out what the patient is allergic to. You'd like to use avoidance along with, treating the rhinitis that exists because they have allergic disease. And then treating other comorbid conditions while you're adding inhaler therapy. So it becomes part of a multi-faceted approach, if you will. Now, just real quick, I would say outdoor air quality is actually a big issue. And certainly nitrogen dioxide, carbon monoxide, PM 2.5s, all of that do absolutely make asthma worse. And it's been associated with hospitalizations, exacerbations. And so I think probably we can say more about that, but that insult is so much bigger than, especially with the wildfires we've been having around the country, than some of the allergen exposure. So you're sort of not comparing apples with apples necessarily, but certainly that has been documented. If you can remove yourself from those kinds of environments, yes, your asthma gets better. That would seem rather obvious, but the indoor environment, I think some more work needs to be done.
Thank you so much, Dr. Kraft. Dr. Shenoy, I'll put this next question to you. There's a question that says, what is the incidence of respiratory infections in our asthmatic patients that use inhaled steroids? And when do we need to stop using inhaled corticosteroids if they have a proven infection?
So, it varies depending on what study you look at. There is a definite link between inhaled steroid and lower respiratory tract infections. That being said, there is somewhat of a dosing relationship with that to the degree of inhaled corticosteroid. But I would like to harken back, like in terms of like actually being admitted for pneumonia, et cetera, the incidence is actually quite low. So, if I really find a patient that's had a true definitive pneumonia, one, I go over their inhaler technique. Two, I go over the ways that they can reduce their overall inhaled. But keep in mind, Monica just presented some data with use of oral corticosteroids that also increases the risk of lower respiratory tract infection. So I think, to be honest, our goal should be to reduce the amount of oral steroids that our patients are exposed to. And I think in general, inhaled steroids are quite safe, and the oral steroids are the ones that we should be going after.
Thank you. The next question is it better to utilize the AirQ to measure asthma risk and control over utilizing ACT? Is it more specific? And I'll start, since actually Monica covered this a little bit in her talk. Remember that the AirQ had good sensitivity and specificity from the studies, but that doesn't negate the ACT, right? And both of you, please chime in. I like, what Dr. Kraft said in the chat earlier is you try both, you see what you like. But specifically, the AirQ does take into account the risk of exacerbations, which ACT hasn't. So I don't think we're here to say one is better than the other. To me, when I take care of my asthmatic patients, I like to use all the tools that are in my armamentarium to try to help get that good assessment and make sure that they're on appropriate therapy. What do you guys think?
Yeah, I completely agree. Yep, I would say, as I said in the chat, I think it's good to try both to see what resonates. The ACT has fewer questions than the AirQ, and so depending on timing and what your practice workflow is like, maybe one works better than the other. I do like the fact the AirQ captures exacerbations, because that's something we think about control in the moment, or maybe over the last month or few months. And really this thinks about, the AirQ thinks about exacerbations over the last year, which I think is also, important, because we don't often go back that far in clinical practice to try to capture that data.
Yeah.
I would 100% echo those sentiments. Like, if you're not going to use the AirQ, I would encourage you to, at the very least, to ask about the exacerbation history. That's very important. Within the last year, within the last couple of years, I always specifically ask about that. Personally, in my practice, I use the AirQ. It's built into my EMR, and it's fairly easy to build into an EMR system if you need to.
And I think that's something that you bring up, Dr. Shenoy, that probably many of us don't do as well. We have these EHRs and they have such great capability. And I'll think about just even the ACT itself. You can build in ACT or AirQ. You can have those built into your EHR, and your patients can complete them before they come for their appointments, right? Yeah. How they do the e-check-in and those things. So you can have it already pre-populated in your clinic visit, which I think would help us all if we were able to incorporate more of that. Let's see. I think maybe one other question has come in, so let me go to it. QA. How significant do you feel is the role of the swallowed portion of the ICS weakening the strength of the lower esophageal sphincter, leading to increased GERD and the related bronchospasm? Dr. Kraft, I'll kick it to you first.
Yeah, so to make sure I'm clear, so that the amount that's swallowed and how that affects the esophageal motility, basically, is what the ask is. Oh, that's an interesting question. I think that's one of the reasons we like spacers, because I think it reduces the amount that you swallow. Because you're right, I worry that the swallowing actually can enhance systemic absorption, because that's another piece that I worry about depending on how the inhaler is delivered. I think that there have been some data out there that there's a relationship between swallowing, because we actually use swallowed inhaled steroids, ironically, for eosinophilic esophagitis. So we actually can use it as a treatment depending on if we think there's eosinophilic inflammation. If we don't, there are some data suggesting some relationship with the lower esophageal sphincter, but I think the data on the systemic absorptions are a bit stronger, and I worry more about that. So again, just brings us back to the spacer discussion and how important that is.
The next question is, any concern about an increased risk of systemic effects from inhaled corticosteroids if dosing 12 actuations of AIRSUPRA in patients who are already using maintenance ICS potential overuse of SABA ICS. So Dr. Schnoor, I'll let you start and I'll chime in a little bit on that one as well.
Mhm.
I mean, so it's all like a double-edged sword, right? Our goal is to prevent oral corticosteroid use. There is, systemic effects of inhaled corticosteroids, as Monica was just talking about. So I think if your patient is using any rescue inhaler fairly frequently or requiring actually 12 actuations per day, you need to bring them in, go over their symptoms, go over everything that they are doing and seeing how you could step up their therapy to reduce the amount of short-acting medication that they use, whether you're using smart therapy, whether you're using albuterol alone, which I don't recommend, or if you're using AIRSUPRA, that's really important. So going also back to a slide that Monica presented, overall the risk of the amount of ICS that you're likely going to be delivering to a patient is way below the FDA guideline risks. So I think overall, no, but if they're using it that frequently, it requires you to reevaluate your patient.
And I'll just chime in a little bit, Dr. Schnoor. If you look at the Mandala trial, Jeff, that asked this question, if you look at it in detail, they really had really good patient adherence in that trial. Like to the maintenance therapy was like 75%. And the average dose of rescue medicine used was like 2.6 or 2.5 inhalations for AIRSUPRA and 2.8 for albuterol. So none of them were getting up to that 12 actuations in a day. And those patients in the trial were told, use this as you normally would your rescue or your reliever medication. So I think that helps us. Plus the reference that he talked about from the Lugogo study that says, hey, even if they use this much, they wouldn't reach that FDA maximum approved dose for the inhaled corticosteroids.
Right. And I just want to add, I think it's more of a sign if they're using that much AIRSUPRA. So as has been stated, I think bringing them in and thinking about, have you treated their comorbidities well? Do they need to step up in therapy, maybe an alternative treatment, a LAMA, maybe even thinking about biologics down the road, sort of thinking, is that to me would be excessive. And I would worry there's something else happening. And this is just a sign of that.
Absolutely. I agree 100%. Well, I think we have reached all of our questions. I think we've had some great questions today, and I just want to thank Dr. Kraft and Dr. Schnoor again for such wonderful presentations and really great conversation around treatment of asthma, particularly with inhaled therapy for our patients. So thank you all very much. Thank you again to CHEST for sponsoring this webinar today. And if there are no other questions, we will give you all a few minutes back into your hour. So thank you very much for joining us and have a great afternoon.
Thank you. Bye-bye.